Okay, good evening, everyone. I'm Dr. Suresh Reddy, interventional radiologist, and today we have the honor of introducing Dr. Neha Sheng. Unfortunately, Dr. Shah, Niranjana Shah, was supposed to be the in the program, but I'm covering for her. Dr. Neha Shah is a board-certified vascular surgeon who works at John Stroger Jr. Hospital of Cook County. She completed both her medical education and residency at Rush University Medical Center in Chicago, Illinois, followed by a fellowship at Loma Linda University Medical Center in Los Angeles, California. Up to 40% of the adult population have some form of vascular disease, and symptoms will vary, with some barely showing any symptoms, while others may have severe complications. When vascular disease affects the legs, it can cause people to be unable to walk comfortably. One of Dr. Sheng's passion is to treat vascular diseases to help patients become more mobile. She is dedicated to taking care of the population of Chicago, especially the underserved. This evening, Dr. Sheng will discuss the symptoms, management, and treatment options for vascular disease that affects the leg. Please welcome Dr. Sheng. Dr. Sheng, you are
Thank
muted.
you. Thank you, everybody, for having me. I'm so excited to talk to you about my perspective on lower extremity vascular disease. If you have any issues with hearing me or the presentation, please type it in the chat. I can see your chat as we go along. I have no disclosures, but I will tell you that this presentation does include some photographs of some medical conditions, and please only continue to listen if you're comfortable with that. So let me first explain, what does a vascular surgeon do? So we treat all of the blood vessels in the body except those in the heart and brain. There are smarter people than me to do that, like heart surgeons and neurosurgeons. And most vascular problems occur because the blood vessel is either too big or too small or narrow. We actually have quite a few blood vessels in our body, and there are 60,000 miles of total length of blood vessels in your body's network of your circulatory system. That is blood vessels that could wrap around the planet 2.5 times. So while there are a ton of blood vessels in our body, today's lecture is going to be a little bit focused on the legs. I think in our modern times where we sit at computers a lot, it's really important that we get walking, get moving to stay in shape. And so this is something I'm very passionate about, and I really try to work as hard as I can to get my patients moving and to make sure that their vascular disease isn't preventing them from getting moving. So in vascular surgery, we we do diagnostic imaging, medical management, and therapeutic interventions to treat blockages in arteries in many parts of the body. But again, today I'll talk about the lower extremities. We also do treat aneurysms where a blood vessel gets too large. We do arteriovenous access, which is what patients who are on dialysis when they have kidney failure require in order to get access to the circulatory system. There are many other things that we do as vascular surgeons, and I've heard other people describe my specialty as the firefighters of the hospital, because when there's a problem with blood clotting, not going where it needs to, or bleeding, I always say, who do you call? Vascular surgery. But there are so many types of doctors who are vascular specialists, and it is very important to me that all of us who work toward treating patients work together to make sure the patient has the best outcome. So you may see people who treat vascular disease who are vascular surgeons like myself. This type of a doctor has either a 5 or 7 year training past medical school and specifically only treats peripheral vascular disease. However, There are many other specialists that for whom vascular disease is part of their specialty and practice as well, and that includes cardiologists, cardiac surgeons, sometimes general surgeons as well, interventional radiologists, interventional nephrologists, that's a kidney doctor, and many other specialties. And it's really important that all of these specialties work together and collaborate to learn from each other and to allow the patient to have the best outcome. So, with that introduction, let's get walking. So, in today's discussion, like I said, we'll focus on vascular disease that occurs in the legs. And we'll start with some less dangerous things, but we will progress on towards some more serious things because I really want all of you to be able to recognize when vascular disease is severe and needs a doctor's attention immediately. What we'll start out discussing is chronic venous insufficiency. And what that means is that the veins are not working properly. That's different from chronic venous disease, just very subtly, in that disease is the manifestation of what's going on inside. And the patient can detect disease by having symptoms. So some people can actually have abnormally functioning veins, but have no symptoms related to the veins, and some people can have severe symptoms. This is a very common disease. Venous disease occurs in 25 million adults in the United States, and that number is a little bit outdated. It's probably even more than that. While it can scare patients, we should actually be reassured that venous disease is generally not limb-threatening or life-threatening, but billions of healthcare dollars are spent on it worldwide. About 20% of men and more than 2/3 of women have varicose veins, which is just one manifestation of venous disease. I can tell you looking at my own legs that I've got a few varicose veins, and I'm sure many of you do. So I'll get into why this is important. Um, with age, the risk can increase with pregnancy, female sex, obesity, genetics, and in people who stand up a lot. There is higher risk of venous disease. Also, in patients who have ever had a blood clot in their veins, there is an increased risk of venous insufficiency. There are some other possible risks, but the one I really want to point out is smoking. And if there is one thing that I can do good in this talk is if I could convince a few of you who are smokers out there to quit smoking. So you'll hear me talk about this a lot. Um, Let me back up for a second and just make sure we all understand what is a vein. So, a vein is a blood vessel that returns blood that doesn't have oxygen back to the heart. That blood then gets pumped to the lungs to get oxygen and pumped back to the heart and out of the heart through arteries. So in this picture on the right upper segment of my screen, you will see the aorta, which is the main artery in the body, and the vena cava, which is the main vein in the body. Through the veins, blood returns back to the heart for circulation. But when we're talking about the legs, there's a little bit of a fight going on, right? Because gravity causes blood to want to go down. We have these amazing things in our veins called valves. They are these beautiful little thin cell layers that close to prevent blood from going down and following gravity into the legs, and open to allow blood to go up back to the heart. But again, because there's this fight with gravity, sometimes those valves don't work for either reasons of genetics or for no reason at all, and sometimes because of blood clots or damage to the veins. And when that happens, we can get venous disease in the legs. There are many different types of veins you might hear about in the legs. So in the diagram that I'm showing here, you have the top layer, which is the skin. And underneath that, there are some superficial veins right underneath the skin. If you look at your own arms or legs, you might see a vein or two. Those veins, when there is too much pressure in them or too much blood in them, can enlarge and become varicose veins. One layer below that, there's a membrane that covers what's called the saphenous vein. The saphenous vein frequently connects to these other veins that are more superficial and can be part of the cause of the problem. We sometimes call the saphenous vein the culprit of the disease with varicose veins. Sorry, I just got a message that you are not seeing my slides. Okay, perfect. And then I got another message that we do see them, so I will keep going. The saphenous vein, again, like I said, is often the culprit of some venous disease. Deep to that, near the muscles and nerves and important arteries of the extremity, are the deep veins. When you hear about the scary kind of blood clot, the kind of blood clots that can go from your veins to your lungs, we are discussing the deep veins. That type of blood clot, if it occurs, does need to be treated with blood thinners. For the most part, most people with venous disease, where I said that 20% of men and 2/3 of women have some venous disease, most of those are just some varicose veins. Again, like the veins that you can see underneath your skin. And so the overwhelming majority of this venous disease is not life-threatening and it is not limb-threatening. It can, however, be annoying and cause symptoms, and there are definitely things we can do to improve that. So there are extensive networks of veins, and let's talk a little bit more about what to do about that. As I said, when the valves in the veins aren't working, blood can back up in the legs because of gravity, and that causes more blood to stay in the veins, causing the veins to have high blood pressure. When the blood pressure is higher than usual, that vein wants to expand. Kind of like when you blow up a balloon, when there's a little more force and a little more air in a balloon, it wants to get bigger. The same thing happens to the veins. And when that pressure gets so big that the wall of the vein can't withstand the pressure, then there can be complications. These complications can include bleeding or damage to the skin. But most patients don't have those severe complications. What most patients feel is a sort of a gradual, dull pain. It's worsened with walking or standing, and sometimes it's actually worsened during the summer times and a little bit better in the cold temperature. This pain can be described as a burning, a pressure, or a heaviness, and it can often have some itching along with it. Most of these patients get relief when they elevate their legs and when they lay down. Sometimes patients even need additional measures to reduce the pressure in their veins, like compression stockings or even ACE bandages. The leg might look like this with varicose veins, where you see multiple spidery looking veins that are underneath the skin. They may have darkening of their skin, and that skin that is damaged by the venous high blood pressure may actually break open and turn into an ulceration that can start out like what you're seeing at the bottom right of my screen and can even turn into a much worse problem. About 1% of people have venous ulcers or have had them in their life. And 10% of patients who have varicose veins can have this happen to them. It results in a loss of millions of workdays per year and early retirement in 12.5% of workers who have venous ulcers. As you can imagine, it's hard to work when you have a large wound to take care of. $3 billion a year are spent in the United States taking care of this. And so, if I can teach you something about preventing this in yourself today, I think that would be great. The way that it's diagnosed is with ultrasound, and I won't get into too much detail on on the details of how the ultrasound is done. But what I mean to say is that you don't need extensive testing for it. A simple ultrasound can explain what's going on in the veins. Most people can be taken care of with compression stockings, which you can buy at Walgreens, Walmart, CVS, Amazon. Almost any pharmacy or drugstore will sell compression stockings. The best kind of compression stocking is the kind that is comfortable for you. So if you notice that you have swelling in your legs at the end of the day, and you notice that you have some veins popping out in your legs, you might want to consider getting some compression stockings. The compression stockings that I generally recommend to my patients are ones that go up to the knee. Although you can get them that go up to the thigh, you can also even get pantyhose style compression stockings that go from both toes to the waist. So those tend to be a little bit more uncomfortable to wear. The knee-high stockings are much more comfortable. You can also get stockings with a zipper so they're easier to get on and off. People who can't get compression stockings on could wear something like an ACE bandage or an elastic bandage to get the swelling out of their legs. Most people who have this problem do not need surgery, but there are surgeries and interventions available for venous disease for those patients whose symptoms are significant. Significant is different for everybody. There may be patients who don't stand up or walk all day that have quite large varicose veins, but they don't bother them. There may be patients who stand up all day and they get so much worse with standing that they can't complete their job, and those patients definitely deserve to be considered for an intervention. Once the venous disease is confirmed with an ultrasound, then we can decide if surgery is an available option for that patient. For those patients who are so severe that they have an ulcer, then surgery can speed up the wound healing, but it's certainly not mandatory for this condition. We do not consider surgery or interventions mandatory for venous disease. It's an option for those people who are really good candidates for interventions. That means that if you have very severe heart disease or lung disease, someone like me may not offer a venous procedure because it may not be in your best interest. The risks might be too high. So we start with reducing the swelling. Like I said, elastic stockings are my go-to therapy, and you can get them almost anywhere. I've seen them for as cheap as $10 on Amazon. Um, you can do other measures such as elevating your legs. I tell people that when you sleep at night, elevating your legs above the level of your heart is the best way to go. Sleep on 3 or 4 pillows under your legs so that the swelling really has a chance to go down and that blood can return to your heart for good circulation. Then, when the legs are skinny in the morning, put on those compression stockings. Minimize your salt intake. In America, we generally eat too much salt. If you don't look at the labels for what you're eating, you may not realize how much salt you're taking in. For example, fast food, junk food, chips, and soda are big sources of salt that we all need to be aware of, and we need to be checking labels when we buy our food. Then, after reducing the swelling, we also want to concentrate on protecting the skin. You saw those first few pictures that I showed you of darkened, dry skin and skin that even breaks into an ulcer. So we want to prevent that. You would be amazed how many lotions and creams that you see at the regular drugstore or pharmacy have artificial fragrances, artificial colors, or alcohol. It would be best to avoid that. Alcohol in lotions actually dries out the skin. And so it's ideal to use something, for example, like Vaseline, Aquaphor, cocoa butter, coconut oil, or anything that you can find that doesn't have artificial fragrances, colors, or alcohol in it. Check your skin every day for wounds or ulcers. Not only looking at your feet and legs, but also look in between your toes because little ulcers can hide in those spaces. And then if there is a wound, then wound care is important. And here's where you need to get in to see a doctor. Sometimes we'll prescribe things like zinc oxide and calamine in order to protect the skin, and then use special bandages for compression to help these ulcers heal. In general, medications are not needed or recommended for venous disease. There are medications available, and I do see people prescribing things like pentoxifylline for venous insufficiency. There's just a little bit of data showing that there's some improvement. But if you don't, I'm of the philosophy that if you don't have to take a medication, if it's not mandatory for the improvement of your health, then there are always side effects, and there are always other things that that medication does to your body. So if it's not a medication that's absolutely necessary, I generally try to avoid it. Those medications are not going to magically heal venous disease, and so they need to be used in combination with compression therapy. For patients with blood clots, not just varicose veins, but blood clots, blood thinners or anticoagulation may be prescribed. Now, those are mandatory medications if the patient has a blood clot and should be taken regularly if they are recommended by a doctor. I'll move on to the possibilities for interventions or procedures that we can do to improve symptoms from venous insufficiency. But I will tell you what I tell every single one of my patients is that I can never make you perfect, and I can never make those veins as good as they were when you were born. But I can certainly do something to control your symptoms. And overall, for the most part, when patients get interventions for venous insufficiency or venous disease, more than 90% of them are feeling better. Not perfect, and I may not be able to get rid of every single varicose vein there is, but more than 90% of people are better. And if that gets them walking more, I'm definitely happy with that. So, starting with the old school techniques, we used to actually remove the whole saphenous vein, and that's still done in some situations. However, oh, and this is a picture of what it looks like passing a device through that saphenous vein and then pulling it out from the inside. It's not hugely invasive, but nowadays we have even more minimally invasive treatments, such as injecting foam that's medicated into the vein to make it close off, or radiofrequency or laser ablation, which are procedures that are done to basically burn and clot off veins that are not working. Those procedures are never done in the important veins. If you remember at the beginning that I told you about the deep veins, that's not what we're talking about, but the superficial veins, usually the saphenous vein, which is often the culprit of varicose veins and symptoms of venous disease. That's the vein that we often go for when we need to treat the culprit of the varicose veins or venous ulcers. Then, although that removes that long saphenous vein, there are still a bunch of varicose veins often left over, and these tiny little 2 millimeter incisions can be made over each one. And although this picture is zoomed in quite a bit, trust me, those incisions are tiny. That's called a microphlebectomy or a surgical phlebectomy. We can remove as many varicose veins as we can get. Again, it's very hard to remove every single one. I'd like to pause for a moment to see if anybody wants to ask me a question right now regarding venous disease. I'm looking in the chat box and I don't see anything right now. So I'm going to go on to talk about arteries. Going back to what I said in the beginning, arteries are the vessels that make.
Actually, Dr. Sheng, this is Dr. Reddy. Can I ask a question?
Yes, of course.
So, sure. So, quick question. Thank you so much for educating us about the deep veins and the superficial veins. As you said, deep veins are more dangerous, and superficial veins are more more physically handicapped and also painful and forming ulcers. Is there a way where patients can differentiate which is superficial and which is deep before even going to the doctor?
Thank you for asking that. For the superficial veins in general, there is a slow onset of um, there is a slow onset of the disease beginning. So you might just see a little bit of swelling or one varicose vein, and it's generally not painful at the beginning, and then it may start getting a little bit worse. When a blood clot occurs in a deep vein, there can be severe swelling, severe pain that occurs all of a sudden. And that should prompt you to go into the emergency department so you can get an ultrasound right away and figure out if there is a blood clot in the veins. Anything sudden or severe is generally a bit dangerous. I hope I've answered your question.
Thank you so much. Also, I have another question. Um, the superficial veins, even though they are physically disabling and also cosmetically disabling, what is the insurance? Is insurance paying, or it is out of pocket, or how does that work for a person with a regular insurance?
That is a great question. In general, when a person has disease that causes symptoms such as pain, burning, itching, or skin changes, the insurances are usually apt to cover procedures for varicose veins, especially if the ultrasound shows an abnormality in the saphenous vein. I sorry, I see a raised hand. Let me just see if I can. I am trying to pull up your questions. Thank you. Just a moment. Okay. One person asked, where does the doctor practice? I am practicing at Cook County Hospital, John H. Stroger Hospital of Cook County, downtown Chicago. And another person asked, what is edema? Edema means swelling. I will go ahead on to arterial disease, and then feel free to come back to any venous questions at the end. So, arterial disease occurs because of blockages in blood vessels, and that can occur because of many different reasons. It can be plaque in the arteries, it can be because of blood clots, and it can be because of injury to the blood vessels. In this talk, I'll discuss mostly blockages due to plaques in the arteries. Those plaques are generally composed of cholesterol and a component of the blood called platelets. That disease process is called atherosclerosis. The general term for this disease is peripheral artery disease, and you may hear me abbreviate it as PAD. These are some pictures of or diagrams of how a plaque forms, and it starts with just a little streak of fat. That can occur as early as a patient in their 20s or 30s. And then that area of fat or cholesterol expands, and it can develop a sort of a cap of fibrous tissue outside of it. And that plaque can even rupture and have blood go into it, which can cause it to expand and cause a severe narrowing in a blood vessel. When a narrowing in a blood vessel causes low blood flow to the thing that that blood vessel supplies, a patient can start having symptoms or consequences. When it occurs in the legs, people can get pain in their legs or even more severe consequences. Arterial insufficiency is a little bit less common than venous insufficiency. And so a bit more than 4% of people who are over 40 years of age in the US have this problem. And that percentage continues to increase with age. So being 7% once you're over 60, 12.5% over 70, and when nearing 80 years of age, more than 20% of people have some atherosclerosis or peripheral artery disease. Men have this disease more frequently than women, and Black men and women and Mexican American women have higher risks than non Hispanic white men and women. It is so important to recognize peripheral artery disease because there are so many more severe consequences for a patient's health with peripheral artery disease or atherosclerosis than with venous insufficiency. So, what happens to these patients if they do have PAD? Well, it depends on how severe the symptoms are. And the symptoms can range from, that first picture that I showed with just a little fatty streak in the blood vessels? It can to a blockage that's very severe. So the symptoms can range from no symptoms at all to pain when the body is stressed. So, for example, walking or exercise can stress the body. And pain upon walking is called claudication. Then, when the human body can no longer compensate at rest for the level of blockages, then a patient can even have pain at rest. They don't even have to exercise to have their pain. And if it's even more severe than that, the skin can break down and there can be a loss of tissues. That loss of tissue will not heal unless there's good enough oxygen and nutrients getting to the tissues. Those patients are at high risk. So let's start small. Let's say the disease is just limited to claudication. An example of claudication would be that the back of my calf cramps up when I walk. For some patients, it might happen at a mile. And for some patients, it might happen at 10 steps or a block. Everybody's different, and everybody's level of blockages is different as well. But once we think you have claudication and diagnose a patient with peripheral artery disease, over the next 5 years, 42%, and over the next 10 years, almost 2/3 of these patients can die of other problems related to atherosclerosis. Most of these problems are heart related. And so it is very important to recognize things early and not only treat the legs, but treat the whole body if there's atherosclerosis. These patients can also even lose their legs if their leg circulation is bad enough and can end up having amputations. Diabetics and smokers and those who present very late, like having had severe disease when they present to a doctor, end up doing a little bit worse. If there is atherosclerosis in the legs, there is probably atherosclerosis in the rest of the body. For example, a person who has abnormal arteries in their legs has a 90+% chance of having abnormal arteries in their heart. And that's why I emphasize this so much because it's a marker for the whole body having disease. And if we catch it early, or better yet, if we do things to prevent this from happening, we may be able to save people from losing their legs and losing their lives. And so, when the disease gets much more severe, patients have a much higher risk of dying within 6 months or losing a leg within 6 months. The risk factors for atherosclerosis include high blood pressure, high cholesterol, smoking, and diabetes. Those are the things we can try our best to control with medications and with vigilant care of our lifestyle in terms of our diet, taking our medications, and not smoking. Of course, we can't control age, sex at birth, and some genetic factors, but there are things we can control, and we should do our best to control that. Of those risk factors that cause atherosclerosis, the worst two are diabetes and smoking. And so I will strongly emphasize the need to stop smoking and to reduce this culture of smoking in our world. And diabetes is also equally important to control. Let's talk for a second. What, if you're the patient, what do you feel? What happens? Of course, there might be this asymptomatic phase at the beginning where you don't have any symptoms, but then you might start catching some cramps when you're walking. Again, I told you sometimes that can happen at a mile if it's the beginning of your disease process. And sometimes that can happen at just walking a block or even less if it's a little bit more progressed. But the human body is amazing. And when you're in this phase of asymptomatic or claudication, we have a chance. We have a chance to prevent it from getting worse, and we can even get better without surgery. Now, I'm a surgeon and I love to do surgery, but when it's not necessary, we should not be doing interventions on disease that we can stabilize or improve with medications and management such as lifestyle changes, stopping smoking, exercising. I'm going to get back to that. Um, when the disease is worse, then even though I said the human body is amazing and can compensate for a lot of things, then if the disease is bad enough that the body can't compensate, there might be pain even at rest and there might be loss of tissues. In those situations, we will call it more critical that the patient gets care right away. So it might begin with some abnormal pulses or weak pulses, a loss of hair in the foot or lower part of the leg, thin skin, thickening of the nails. Every now and then there can be some swelling, although swelling is more of a marker of vein disease than artery disease. Sometimes a patient with lighter skin can get redness in their foot when the foot is down and a loss of color in their foot when the foot is elevated. Then the cramping can start when the patient walks, and that's only pain with exertion. These patients are relieved when they rest, and it generally occurs at a low level of disease. Men can also get sexual dysfunction if the disease is in the iliac arteries, which are arteries in the lower part of the pelvis. This is the color discrepancy I was describing that can occur when a patient's legs are down, and you see on the right side of your screen that the foot is a little bit more red when the person has their legs down. And if you elevated that leg, you might see the color drain from the leg. This disease usually occurs in the part of the body that's furthest away from the heart. Then the tissue may start to break down. You can get small ulcers and you can get gangrene. This can be associated with infection, and those infections can be limb and life threatening. That means that a person could lose their leg or even lose their life from that type of problem. When there is not good enough circulation to get oxygen and nutrients to the foot to heal up wounds like this, then surgeries or interventions can be required to increase the circulation. Again, when we get to that point of pain at rest, no relief from the pain, or even loss of the tissues, then we have to act right away. We have to get to a doctor right away because only 40% of these patients are alive with their leg in the next 6 months. And so, what do we do when we find a patient who has these problems? Well, it depends on how much disease they have. And if they don't have gangrene or tissue loss or pain at rest, then we often don't need extensive workup. We start with a very simple test called an ABI. What you're seeing in this picture, and don't worry too much about the details, but what you're seeing in this picture is an evaluation of what the blood vessels should look like on an ultrasound, where you see the changes in the blood vessel with every heartbeat. And in this picture, what you see on the left side is that patient's waveforms from the ultrasound look a little slower, a little less sharp than on the right side of the screen or the left side of this person's body. That means that there's a little bit of disease. Again, don't worry about what you're seeing on the screen, but what I'm trying to say is this is a simple, non-invasive test, just a little ultrasound. We also check the blood pressure in the arms and feet and we compare them. If that's abnormal, then we say this patient has peripheral artery disease. They probably have atherosclerosis. And remember, I said earlier that if there's atherosclerosis in one part of the body, it's probably in the rest of the arteries of the body as well. If there's atherosclerosis in the leg, there is probably a 90 or there is a 90+% chance of having atherosclerosis in other parts of the body, like the heart. Um, that means that we have to treat atherosclerosis in the whole body, not just in the legs. So we're not talking right now about surgeries in the legs, especially in patients who don't have very severe symptoms. But that doesn't mean we're doing nothing. We need to make some changes. And I tell patients when I detect this disease early that this is your opportunity to get control of your life, get control of your lifestyle and modify those risk factors. Whatever we can control, let's control it to prevent those bad outcomes. So that starts with exercise. And if it hurts to walk in the legs, then stop. But that doesn't mean you don't start walking again. And stopping smoking is the number one most important thing these patients can do for their health. For their health. Control of diabetes and certain medications will also help. So we'll talk about the nitty-gritty of each of those for a second. Smoking is directly related to worsened outcomes from peripheral artery disease. People who quit smoking will not progress as much to having that limb-threatening ischemia where you can lose your leg as smokers. The difference is 8% versus 79%. That is a huge difference. Structured programs are available through many doctors' offices and hospitals where there is a smoking cessation counselor to help a person get a plan to quit and then go with that plan. Most people who quit smoking will end up starting smoking again at some point, but that's okay. You just have to keep trying to quit again. The rate of success again is better when you have help. We human beings, we are social beings. We don't like to do things alone in this life. So maybe get a friend to quit smoking with you or have your doctor prescribe an actual program. There are certain medications that increase the rate of success of quitting smoking. For every 1% increase in your hemoglobin A1C, which my diabetics out there will probably know, your doctor checks every 3 months. This helps you understand the level of diabetes. For every 1% increase in that is a 28% risk of increase in PAD. So it is it is essential to control our diabetes. Diabetes results in abnormal metabolism of cholesterol. It results in more blood clots and more atherosclerosis. I know I've used some complicated words here, but don't get hung up on that. Let's get our sugar under control as a population, not just my diabetics, but all of the non-diabetics out there too. I want everyone to think about the next time you're about to eat a dessert, do I really need this? Okay. Next is high blood pressure, and it's very important to know if you have high blood pressure because high blood pressure doesn't necessarily cause symptoms. You might not know if you don't see a doctor regularly. So see your doctor regularly. Every year, see a doctor, get your blood pressure checked. Keep your salt intake under control. Fast food, junk food, soda, these are all culprits for too much salt. Decrease your alcohol intake and increase your physical activity, your calcium intake, and maintain a healthy weight to help control this. Cholesterol. We need to eat low cholesterol diets, and statin medications are like a wonder drug. It is very rare for people to have true significant side effects to statin medication. So if your doctor has prescribed you a statin, please take it. The there is improvement in both your risk of progression of artery disease, plus how long interventions like surgeries for artery disease last, and a reduction in your risk of stroke, heart attack, or cardiac related death. People who have claudication, that cramping when they walk, can even walk longer when they're taking these medications. So, these are medications that if your doctor wants you to take, please be compliant with. The next one is antiplatelet therapy. You might see names like aspirin, Plavix, clopidogrel, and there are many others. The most simple of which is a baby aspirin. If your doctor prescribes this for control of your atherosclerosis, please be compliant with it and take it. You shouldn't be starting those medications on your own, but in consultation with your doctor, if this is recommended, please do be compliant and take it. Next, the hardest thing to do because we're all so busy, but can you commit 30 minutes every single day to walking? It will decrease symptoms of claudication, improve survival rates. Over 5 years, there's a 30% improval in survival rate in people who are in an exercise program and really walk. And so, if you don't have the access to an exercise program, find a buddy. Can you walk with a buddy? If it's freezing cold outside, can you walk back and forth in your house for 30 minutes? I know it's hard, but find the time to do it. A lot of people can't do it if their heart won't let them or their lungs won't let them. But if you're one of those people who can, please do it. 30% of people, unfortunately, refuse to exercise, and I wish we could get that number down. The American Heart Association recommends 30 to 45 minutes of exercise a day, at least 3 or 4 times a week for at least 12 weeks to improve the symptoms of PAD. But we know that this doesn't just improve PAD, it's going to help us control our weight, reduce our heart disease, and improve our legs. Water is our most important resource. So many people don't know that drinking 2.5 to 3 liters of water a day has actually been shown to improve the distance that people with peripheral artery disease can walk 5x. That's amazing. That's an amazing improvement. And so, if you can avoid surgery and drink some more water and take those medications, all the better for you. It also improves blood pressure in the lower extremities in people who have poor circulation. However, not everybody is allowed to drink as much water as they want. So if you have kidney failure or heart failure, you need to consult with your doctor about this. So I've talked a lot about non-surgical things, even though I am a surgeon. And as I said before, I do love to do surgery. But which patients really need it? Only those patients with claudication or just pain in their legs intermittently who don't improve after all of these measures, exercise, medications, and modifying their risk factors, stopping smoking, controlling their diabetes, cholesterol, and blood pressure. Still no improvement. I'm here for you, okay? Or anybody who is a vascular specialist is here for you, I should say. And then those who have much more severe disease, like pain at rest and loss of tissues, like ulcers or gangrene. And what interventions can be done? Numerous. It depends on the anatomy of the disease. This is just a picture to show you that the disease in the blood vessels, the yellow that you see is plaque in the blood vessels, can be anywhere and everywhere. And if there's a focus of a blockage, then we can do something to get around that. Or if there's a narrow blood vessel, we might be able to do something to expand that narrowing. Some examples of things that can be done, starting with the least invasive, are balloons that are put into the blood vessels and inflated in the blood vessels. That's called an angioplasty. It can even be done with medications coating the balloon to infuse medications directly into the area of disease. Stents can be put in for a more longer term solution in certain areas of the body. This is called atherectomy, which is basically a roto-rooter that goes in to sand down the plaque. And then there are other techniques for worse blockages, such as removing blood clots or plaques. This is a picture of actually pulling out the blood plaque, the plaque in a blood vessel and then sewing it up. Sometimes we sew it up with a patch so it doesn't get narrow again as frequently. This is a picture of a bypass, basically using a vein that you don't need or an artificial vein to go around a blocked blood vessel. And that can be done at many different levels of blood vessel disease in the body. But there's no free lunch in life, and we don't do surgery for no reason. So there's always risk of complications, and your surgery, you can say your surgery is only as good as the worst possibility of complication, because if that happens to you as the patient, then you have to suffer with it. So we only do surgery when there's a good reason to do it. And nothing we do will restore perfect circulation, but we can certainly make patients a lot better, and we can certainly improve the function of a limb as well as prevent amputations when we do all of these things at the right time. All right, I will pause for questions. And Dr. Reddy, if you have anything to start with, please do go ahead.
Thank you. That was a wonderful presentation. I think it went through the whole arterial and venous system. Any questions, anyone?
Um,
Let me
there
see
are
the let me see
There
the
are a
question. Yeah.
few questions in the chat. I'm going to start with the last one. If there are preventative tests available to detect atherosclerosis, just having your doctor, your regular doctor that you see every year for a checkup, just double check your pulses in your feet and your arms is the most simple and easy test. If they don't detect any good pulse, then you can start with that ABI test where I showed you all those funny looking up and down lines. That is the ultrasound. That's very simple to do. Let me try to get to the Q&A. Somebody said, what about cramps in the legs while sleeping? That is a fantastic question. Cramps in the legs because of blood vessel disease usually occur with walking and not necessarily while at rest. Rest pain that I discussed because of blood vessel disease is more often in the foot. So cramps in the legs while sleeping is usually something else. A couple of things that you can do if you don't have heart failure, consider hydration. And then tonic water with quinine you can get at some grocery stores can help leg cramps when you're sleeping. That's called restless legs syndrome. Restless legs syndrome. So you can look that up if you want to, or please do consult with your doctor. And somebody else in the chat asked about, does taking omega-3 cod liver oil help? There's a lot of data that omega-3 fatty acids do reduce inflammation and improve blood vessel flexibility. So I have a slide here, and I'm just going to give you the caveat that there is no supplement that's going to replace a healthy, balanced diet that's full of fruits and vegetables, low in cholesterol, low in sugar, and low in salt. But there are some things that have been shown to be good for the circulation. Specifically, it's like the G's, ginkgo, garlic, and ginger, and then turmeric, omega-3 fatty acids, and I haven't personally used these, but L-arginine and coenzyme Q10 do have some data, but I don't personally prescribe supplements for my patients. I'm not opposed to them. It's just not something I have in my training have prescribed.
Thank you, Dr. Sheng. I have another question. Can you hear me?
Yes.
Um, Especially for people flying on long distance international flights, any precautions you would suggest, recommend?
So definitely getting up to walk as much as you can. And even if you can't walk, you can bend and straighten your leg a little bit at your seat. You can move your ankle up and down and your toes at your seat as much as you can. You can wear compression stockings. And, there are some medical conditions for which a doctor might prescribe medications to prevent blood clots on a long flight, but that should only be done in consultation with your own primary doctor. Okay.
Any other questions?
There is a couple of other questions I am seeing, and A person is giving an example for an older smoker in their 80s who has severe blockages, and the cardiologist cannot do open heart surgery. They're on blood thinners and awaiting a procedure. Um, you know, it is not really possible for me to give specific medical advice about a patient who I have not seen. So I don't think I have enough information to answer that question. And if it's regarding something that is planned by a cardiologist, I am not a heart doctor. So I'm not going to answer that question. But I'm happy to entertain any other questions you'd like to ask me. Somebody else asked a question about still have hairs on toes, but loss of hair at the lower shin. And this often happens in men whose socks do wear off their hair at the lower, like ankle and lower leg, but they still have hair on their toes. And so if there's hair on the toes and no symptoms of peripheral artery disease, and your doctor checks your pulses and they're fine, I wouldn't worry about that. Um, Somebody said, what do I think of the CIMT test? Let me confess that I don't know that abbreviation off the top of my head, so I'm going to look at it on my phone to see what is CIMT. Oh, carotid intima media thickness. Both ABI, which is the test that I demonstrated in my slides earlier, and carotid intima medial thickness are um, possible ways to screen for atherosclerosis. I don't practice at a place where we regularly do CIMT, and I never have, although I did couple of times in my medical school training. So my regular practice is with ABI testing. Whatever your doctor feels comfortable with for screening for atherosclerosis is perfectly appropriate. Any other questions? Well, if there aren't any other questions, it has really been my honor to talk to you about something I'm very passionate about. And I hope that I can get a few of you to quit smoking, walk more, drink more water, and eat a healthier diet. I'll wait on the chat for a few more minutes if anyone wants to write out any other questions, but thank you again.
Thank you, Dr. Sheng, and it's a wonderful talk on the arterial and venous system. Wonderful information. Thank you.
Thanks, Dr. Reddy, for moderating. Really appreciate it. Okay, I
Thank
think
you.
it looks like we can sign off now.
Okay, thank you.
Okay.